Welcome to The Kingstonian, a podcast that profiles people who are passionate about what they do for a living, what organization they belong to, or the community they are a part of. Here is your host, Dave Cunningham.
Thank you, Steve. Hello, everyone, and welcome. COVID-19. There continue to be questions and concerns. Theories abound about what works and what doesn't. In this episode, we will attempt to address many of them with a specialist in the field. Dr. Gerald Evans is chair of the Division of Infectious Diseases and a professor at Queen's, and an attending physician in Infectious Diseases and Internal Medicine at Kingston General Hospital and the Hotel Dieu Hospital in Kingston, Ontario. He's been working in this field for over 30 years and is well qualified to help us all understand what science has learned so far about COVID-19. Here is our conversation. Dr. Evans, welcome to the program, and thank you very much for your time today.
Thanks very much, Dave. I'm happy to be here, and thanks for the opportunity to chat.
In the preamble to the program, I outlined your qualifications, your experience, and I noticed that working with infectious diseases is something that is a prominent part of your work life. Why that particular discipline when you first started out many years ago?
It's a great question. I actually know all the answers here. See if I can try and make them as succinct as I can. I went to medical school at the University of Ottawa, and when I came out, I kind of had as an inkling I probably wanted to be a bit of a diagnostician. And so I went eventually into internal medicine, having had a slight bypass to anesthesiology. I was always interested in the sort of general aspects that infectious diseases are about. So unlike a lot of my colleagues who are subspecialists in things like the heart as a cardiologist or the lungs as a respirologist, I kind of like the idea that I was dealing with an etiological specialty. In other words, I would have to really know a lot about a lot of different organ systems in the body, because I was looking at it from the aspect as an infectious disease doc of the cause of it, the pathogenic cause of it. So that was always very, very appealing. And in many ways, I think most people agree that infectious disease doctors like myself tend to be pretty good diagnosticians. So that's what really appealed to me. And I can say it goes really far back. When I was a kid, I read a book which was an autobiography of Robert Koch, who was the famous German microbiologist in the mid-19th century, who was the discoverer of anthrax and ultimately contributed to a lot of what we know about tuberculosis. I was just always fascinated by microbes and their ability to cause disease. So that's kind of really that thing that pushed me into infectious diseases as a medical subspecialty.
In all of your time working with infectious diseases, did you ever think that a disease like COVID-19 would become so pervasive, so deadly, and become so much a part of the lives of almost everyone around the world?
In a weird way, yes. And part of that relates to the fact that back in the early 2000s, I was involved in pandemic influenza planning. I've had a strong interest in influenza for many years as an infection, and got pulled into some federal planning groups, particularly antiviral groups that were sort of looking at how we would handle it. And so I remember at the time, and I wish I had recordings of me saying that, we're sort of so focused on influenza as a pandemic that maybe something's going to come out of left field. And lo and behold, COVID-19 sort of came out of left field to some degree. And this other surprising thing about it is that I actually, when I was a young man and still training in infectious diseases, I did a research fellowship with Dr. Bob Anderson at the University of Calgary, and I studied coronaviruses. So we actually happened to study a thing called mouse hepatitis virus, but a lot of the knowledge I picked up about coronaviruses also, kind of suggested to me that this might be an issue. So all ID doctors worry about pandemics, and this one really has really shown us what a modern day pandemic looks like, recognizing that the last time we ever faced something like this was way back in 1918, 1919 with the Spanish flu.
There has been a lot said and written about COVID-19, particularly with social media becoming such a big part of our lives. Some of the statements are true, some of the statements are not true. And I would like to beg your indulgence and go through a bunch of them and get your take as someone who has been involved in this area for 30 years plus, and see what your thoughts are and get the word from a man of science. And let's start off with one that I hear an awful lot, and that's, I am double vaccinated, so I have the suit of armor around me. I cannot get the virus, nor can I spread it.
Right. So there is an only small modicum of fact in that statement. What we know is that full vaccination, does provide some degree of sterilizing immunity. With the previous alpha variant and the original SARS-CoV-2, that protection was about 70 to 75%. With the Delta variant, it's a little bit different. It's lower. It's probably about 60 to 65%. But it still means that there's still a strong possibility that you could get infected even though you're fully vaccinated. The issue about transmission immunity, that is the inability to transmit the virus once infected if you're fully vaccinated. Again, we've got some pretty good evidence now to suggest that although fully vaccinated people could transmit it once infected, the time duration that they're likely to be shedding virus and the amount of virus that they're shedding in that period of time is markedly lower than it is for people who are unvaccinated or perhaps only vaccinated with one dose. So the answer is you can still be infected, you can still transmit it, but you're much less likely to have either one of those two events if you've been fully vaccinated as compared with someone who is unvaccinated.
And if you do get the virus, and you are fully vaccinated, then the odds of you spending any time in the hospital is quite limited. You should be sick at home, perhaps a bit of a cold type of symptoms. Is that true?
Yeah, no, that's bang on. That one of the most powerful effects of these COVID-19 vaccines, and I'm talking both the mRNA vaccines and the adenovirus vector vaccines like AstraZeneca and J&J, is that they offer enormous protective immunity. So that's the immunity that protects you from getting seriously ill. And that is way up there. It's probably in the range of about 90 to 95%. And even with Delta, we're seeing that protective immunity in substantial numbers. And again, what you're likely to experience is either no symptoms. That's been very well described in fully vaccinated people who've acquired the infection. But even if you get sick, it's usually very mild. As you said, it probably is going to be a kind of a bad cold. Very unlikely to end up in hospital ICU, and of course, a dramatic reduction in the likelihood of the ultimately bad outcome, which is death. So the vaccines really do provide enormous protective immunity to people who receive all the vaccines.
When it comes to variants, and you've mentioned the Delta variant, and that's the latest one, seems to be the one that's causing the most trouble. What prompts these variants to come into being, and can we expect others to make an appearance?
Yeah, that's a great question. So this is, I'll try and make this as simple as I can, but it's a little bit of basic virology. So all viruses make mistakes when they replicate. And some viruses do it a lot more and some do it a lot less. The surprising thing about SARS-CoV-2, the virus that causes COVID-19, is that it actually doesn't mutate really at anywhere near the frequency of a more common virus, for instance, like influenza does. Having said that, every time a person becomes infected around the globe and gets COVID, they have a lot of viral replication going on during the period of their illness. And so the reason that these variants are rising, relatively consistently at this point is because we just have a global burden of disease which favors the virus making all these random mistakes. And I think it's really important that people understand the virus isn't a thinking object. It makes these mistakes because replication of nucleic acid like RNA and DNA is always full of mistakes at that level. And so these mutations are going to happen. The interesting thing is most of the mutations that would produce a variant are actually very adverse to the virus. They actually make the virus less infective and less virulent, et cetera. And so they actually die out. But if you have enough of them, as we've seen, and some of them favor the virus to be more transmissible, perhaps, then that's going to effectively, if you think about the law of natural selection, it's going to replace other viruses that are out there that are less likely or less able to transmit. And that's what we've seen with the Delta variant, and it's what we saw a little bit with the Alpha variant as well, when you compare it to the original virus that arose in China.
Some people are already getting boosters for the vaccine, and I'd like to know what your take is on what you expect to see with respect to whether or not we'll have to get ongoing injections of the vaccine going forward.
Well, that's a great question. So right now, the weight of evidence suggests that certain populations may need a booster, because what we can do in measuring their antibody levels is that they seem to drop off. Now, that's a bit of you have to be very careful with that, because you're then assuming that the level of antibodies in the blood is a surrogate marker for protection. And what we know is that your immune system is much more complex than that. And with lots of good memory B cells and T cells, you can fire off an immune response, even if at the time of your infection, your antibody levels are low. But that seems to provide some protection. Where do we see those lower antibody levels after full vaccination? We see them in people who have transplants, so recipients of transplanted organs. The kind of immunosuppressive therapy they're on seems to produce that problem. The other one is people who have certain kinds of cancers, mostly cancers that involve the blood. So we think of things like lymphoma and some of the other disorders that are associated with particular lymphocytes called B cells. And we also are concerned about people who take drugs which deplete their B cells. And that's very common for people who are suffering from lymphomas, et cetera, because the drugs that we use, a drug like rituximab, knocks out your B cells. So those groups in particular need a booster at this point, based on the fact that their antibody levels seem to be lower and that we can boost that with a booster. The other group that's popped up is very elderly individuals. So I'm talking about people who are, and I always make a joke that my definition of elderly has continued to rise as I age. I think that's
I know the feeling.
So really, people who are, right now we're looking at people over 75 to 80. If they got their vaccines very early and they were in the priority group for vaccination here in Canada and in Ontario, where I live, if after about 8 months we think their antibody levels drop off, and we know that they're less likely to get as vigorous a response to vaccine than you would expect, for instance, in a child, an adolescent, or a young adult. So that group we're starting to believe probably needs a booster now at about 8 months from the time of their second shot, so when they were fully vaccinated. Those are the groups where we can really pinpoint that booster is needed. If you're a generally healthy person and you're under the age of 75, and you've had your vaccine, your full vaccination date, less than 8 months ago, there's really no requirement for boosters at this point. And it's really interesting because coronaviruses in general, if you look at them as a group, and there's a lot of human coronaviruses that have been around for many years that cause the common cold, OC43, 229E, I can go on and on with all these odd numbered lettered things. When we study the immunity to those viruses, what we know is that protective immunity, the immunity from getting seriously ill with these viruses, actually lasts quite a long time, years, if not even decades. But the sterilizing immunity, the prevention of actually getting infected, that's a little bit more short-lived. And if SARS-CoV-2 follows that pattern of what we see with human coronaviruses, then it does suggest that if we're trying to prevent infection and transmission, we're probably going to need boosters. However, if we're just looking at trying to protect people from getting seriously ill and dying, then boosters may be not as important a strategy going into the future.
I have a whole pile of questions here, and I'm going to bounce around a little bit and try and get as many answered as possible in our time frame here. These are folks who do not want to get vaccinated, and some of the issues that come up with them. One of them is the vaccines we are looking at right now were developed too quickly for me. How do you address that particular feeling?
Yeah, so if you look at the mRNA vaccines, that technology has been around for decades, and it's been used to develop rabies vaccines, vaccines against some cancers, and now being used, of course, to create vaccines against things like malaria. So that's not really true. These vaccines and the technology behind them has been around for decades. And what we were fortunate is that we got to the point when the pandemic took off that these were highly developed strategies, and it's why we were able to roll out the mRNA vaccines in particular within months of the pandemic rather than years. So not really a criticism. This technology has been around for a while.
Some people believe that the vaccine, once injected, will have long-term effects. And someone told me that the vaccines themselves don't stay in the body that long. I'm not sure how that all works. And if you can explain it in layman's terms, that would be great.
Right. So this usually suggests some rudimentary knowledge of molecular biology. So these vaccines, once injected, the mRNA code, which is the template for a protein which you then make an immune response to, happens very quickly. And then that mRNA is destroyed. And that we know from lots and lots of studies, it does not hang around your body to create problems going down the road. And the fact that it disappears quickly, which was one of the things you pointed out, actually is a good part of it because, once that mRNA is gone, it's done its job. It's made some little pieces of spike protein for your immune system to mount an antibody response. Then it's not going to hang around and cause other problems. A lot of people have been kind of worried that somehow this is going to change your genetic structure. And again, mRNA is never converted into DNA, which would be part of the genetic code. So yeah, that's a lot of what I kind of think is a little bit of, there's an old expression, there's nothing worse than just a little bit of knowledge and something to kind of mess it up. But none of those are really true at this point. And long-term effects, yeah, sure. We're still looking at what's happening, but we haven't seen it. And there's been over 1.3 billion people around the world been vaccinated with COVID vaccines and no long-term effects. So if they're there, they're going to be extraordinarily rare.
Some of this next question applies to the political side of all of this, and that's the freedom to do or not to take a vaccine if they don't want to take a vaccine. And what I have heard is that, okay, I am young, I am healthy, I can deal with whatever COVID-19 throws at me and get better. So why should I take a vaccine?
So the reason you should take a vaccine is because at every age group, it reduces your risk of dying. And it reduces your risk of hospitalization. And what we've discovered with Delta variant, with all of the things that are going on in the States, and unfortunately, the United States tends to be a classic example of the attitude of don't vaccinate me and just let me do what I want to do. Of course, what have we seen? We've seen young people, young adults, adolescents, and even small children who are suffering severe consequences, including death from COVID-19. This for me, if you'll pardon me saying, is a no-brainer. If you can give me a vaccine that's going to reduce my likelihood of dying from 1 in 1,000 to 1 in 10,000 or 1 in 100,000, that's a good vaccine. That's an amazing vaccine. So what we've learned is your health, your health and your age to some degree really aren't protecting you. Age, yeah, for sure. If you're younger, things are pretty good, but too many circumstances where young, healthy people have died of COVID-19. There's a lot we're still learning about this disease. So I would really encourage even young people to get the vaccine. You don't want to take that chance. You don't want to be one of those people who, your family mourns the passing of because simply you didn't take the vaccine when you could have.
As a doc, are you in favor of making vaccines compulsory?
I certainly am into mandating vaccines in certain areas. So I work in a hospital. And I think if we're going to maintain our ability to not just care for COVID patients, but to care for everybody who has health issues, then I think we need to mandate vaccines in the hospital environment without question. We cannot put our patients at risk of getting infected by not being vaccinated and allowing unvaccinated people there. And the other thing is that vaccination protects your fellow workers in the hospital, whether it's other doctors or nurses or whatever. The fact of the matter is that the vaccine really helps. I think right now, the other group that I would say I think is worthy of a mandated vaccine would actually be those who work around children who are not eligible for the vaccine. So I'm talking now about school teachers and staffs in elementary school, and to some degree high schools as well, and of course even at universities like where I work. And that helps to really protect those children in particular in the elementary level from getting infected. Even though infections in the school place are relatively uncommon, Delta's changing some of that, and that's what we have to be worried about. So yeah, I favor it in many aspects. I guess I could expand it even also just very quickly to other groups that we really need to have around. And who are those? Those are the first responders. Those are ambulance workers, paramedics, firefighters, the police, and lots of other people who really, we need them, and we need them to be available. And this vaccine is going to allow them to keep themselves safe and to keep all of us safe by the work they do.
Now, review for me, kids. You mentioned kids a couple of minutes ago. So I believe we have vaccines available for kids from 12 to 18.
Correct.
Is that okay? But we don't have anything for kids under 12 yet.
Right, and that's coming. And I'll throw in my question I'm often asked this, which is when is it going to be available for kids? And I think right now we're looking at probably by mid to late October, children between the ages of 5 and 11 will likely be eligible. I've seen the early efficacy data, the effectiveness of the vaccine in that age group, and it's tremendous, as you would expect with any childhood vaccine. Kids do great with vaccines. The only reason it's a little bit delayed at the moment, because we were expecting some potential results right now by the beginning of September, is that many of the regulatory authorities have asked for larger numbers of kids to be enrolled, so they can make sure that there isn't some kind of rare safety signal that they haven't spotted with the current numbers that are in the vaccine trials.
Are there some side effects going on with kids who are around 12 or in that particular range that are of concern, that are being addressed or are simply not there?
Well, the only thing that's popped up, and it's probably in a slightly older age group, is this issue about inflammation in the heart, something called myocarditis or pericarditis. And that has been seen with the mRNA vaccines very rarely, typically with the second shot in younger individuals, and particularly young males. But in the very lowest age group, the sort of 12 to 16, it's still very, very uncommon. And the really good part about that is that almost all cases are very mild and they recover completely. So it's a short-term adverse effect, which does not seem to have any sort of prolonged signal. So I really try and reassure people that the vaccine should be given in that younger age group.
Now, when we talk about numbers of those who have been either vaccinated completely or have had at least one shot, at this particular point, because we are in Ontario, do you have any numbers you can throw back at me to indicate where we stand with that? I mean, you look online and the numbers seem to change quite frequently. So I thought you might have more current numbers.
Yeah, so I looked at some numbers just recently. So if you look at people who've had at least one shot, we're well up into the 82 to 83% range. And that's an important number because almost everybody who took one shot is likely to take a second shot. So that's probably where we're hitting our current ceiling with fully vaccinated as we continue to roll them out. In terms of fully vaccinated, we're doing amazingly well, particularly here in Ontario. We're looking at 75 to 76% of people are fully vaccinated. And those numbers are extremely uncommon around the world. Canada has been a leader. And I would say in particular, some of the provinces like Ontario and Quebec have really, really been at the top of those numbers. And that puts us in the sort of circumstance that we're seeing in Singapore. Singapore has over 80% of people fully vaccinated. And if you look at the numbers of cases that they've seen that have required hospitalization or serious cases or deaths, it's dramatically lower than you see in countries like the United States. And it's important when people look at the US numbers, they recognize only 52% of the United States is fully vaccinated. So that leaves a substantial number, somewhere close to 150 million people who are unvaccinated. And that's why we've seen the numbers we've seen in the States. So yeah, we're looking very good here in Canada and very good here in Ontario. Always like to have it higher. We really need to get up above 90 to 95% to see and reap the benefits of that full vaccination rate.
When you give me those numbers for Ontario, for instance, what age range are you talking about?
So we're talking about the percentage of individuals 12 and older. So that's everybody but the kids. A second the vaccine's approved for children, we're going to see a massive jump in that number because of a large percentage, and I'm talking over 80 to 90% of parents are going to get their kids vaccinated. Judging by the kinds of things I've seen with parents being very worried about their child getting COVID, I would expect that would jump. And that will push us easily into the 90% range, just because we're just going to grab all of them. And we have seen, by the way, a continued steady increase in people now coming in for first vaccination. And that's because they're starting to see what is undeniably the effects of not being vaccinated at all, which is serious illness and death because of the transmissibility of Delta as it gets into areas.
Do you have any sort of sense as to why the numbers in the States are so low compared to, say, Canada?
I guess when I look at the kinds of things that are written by people who are really experts in the area of understanding this, a lot of it is political and ideological. For a long time, this divisiveness in the States, particularly with people who were former supporters of the former president and who align themselves with the party that he represented, basically tied not being vaccinated to ideological purity. And they've suffered serious consequences because of that. There's no question, if you look at the political demographics of the states in areas where there is less influence of that kind of messaging in the Northeast, to some degree in the Northwest and the Southwest, things are looking good. But down in the Southeast and in the Midwest, where that ideological political bent is common, that's where we've seen the huge jump in cases. And you can literally overlay a map of the large number of cases and hospitalizations from COVID with a map that shows you where people are vaccinated, not vaccinated. And that really does follow, unfortunately, a little bit of this sort of divisive population that's present in the United States. So it's an unfortunate problem that's really, I think, an offshoot of a debate that's outside the range of what I'm certainly an expert in discussing.
Well, speaking of the former president and some of the magic bullets that have been spoken about over the last year and a half or so, and can you give me your take on why, for instance, hydrochloroquine received so much attention early on, but it was rejected as any kind of cure or treatment for COVID-19?
Yeah, hydroxychloroquine is an interesting problem. So first of all, it was promoted a lot by the former president of the United States, actually at a press conference. Yep. Secondly, there was a colleague of mine who otherwise has had a very good reputation. His name is Didier Raoult. He's a French infectious disease physician and researcher and scientist. And he very much promoted it based on a very small clinical trial, which was really subject to a lot of confounding, meaning there could have been other explanations for why it seemed hydroxychloroquine worked. Subsequent to those, and so that really pushed it forward. Subsequent to that, we did see lots of larger clinical trials in which hydroxychloroquine was used by reputable groups in larger numbers, and it was clearly not an effective treatment for COVID in any shape, manner, or form. And in fact, there was probably a lot of worries about a safety signal. It created harms because the drug can be toxic when used in people for various reasons, especially in high doses. So it went out fairly quickly, but it was really the generator of a lot of interest in having an alternative to vaccine, and so has been heavily promoted in social media. It and other compounds, more recently ivermectin, have been pushed by people who are trying to claim that these are alternatives to being vaccinated, so that it falls into whatever ideological or personal reasons they might have for not being vaccinated. And that little infodemic has been a real challenge for us during the pandemic.
I had a discussion with a guest that I had on the program a couple of months ago, and his name is John Small, who is in the biology department at Queen's. And we were talking about the impact that men of science are having on the general public. And there was a time when people followed what was being said by politicians more so than scientists. And I have the feeling, and I think he agreed to a certain degree, that seems to be turning around a bit with people like yourself and other people of science who are getting a lot of play in the media, expounding on what's going on. And do you get that particular sense that there is more attention being paid to scientists as opposed to people who are doing things for ideological or political reasons?
I guess my wish is yes. I hope that's the case. I think it is to some degree, but it really is continuing to line up people along what's an ideological divide. You know, that people have various personal and other reasons why they may favor one answer. And one of the problems that we've run into, and certainly have understood during the pandemic, is that there's a lot of cognitive bias at work. If you believe in a certain thing like vaccines, then you're going to follow the kind of people who promote vaccines like myself and others, and you're going to listen to what we have to say and perhaps add some credence to it, especially when the evidence comes out that it works. On the other hand, if you're already biased towards the idea that vaccines are harmful, you're going to line up still along the edge of the political side of things, because oftentimes that is embraced by certain individuals in the political and or cultural field, and then that sort of skews you that way. But I think we're starting to see that the majority of people in the public really line up on the idea of tell me a little bit about what's going on. How does this happen? Show me the evidence that something is either effective or ineffective, and then I'll go with that. And so, I sit on the Ontario COVID-19 science table, and we've been very much promoting that kind of messaging. And we feel that most of the public really does realize that there are good answers that can come from science, and that they have to be a little bit more skeptical about the motivation that may occur in political individuals or others, especially right now we're in the middle of a federal election here in Canada, to where things are going. So it's my hope that that will continue. On the other hand, I recognize that in a democracy, we elect leaders, and we elect leaders at the behest of the voters. And so voters, in a way, should have an expectation that their politicians should not take into account political motivation, but rather, in this case, during a pandemic, the scientific evidence that supports, should you or should you not mask? Should you or should you not get the vaccine? Should we continue public health measures? Should we have vaccine passports? All of those things should have science backing them up when they make those decisions, rather than the sort of idea of, well, who should I appease here because an election's coming up and I need to be elected?
Does social media make your job easier or more difficult in communicating your message?
Ooh, it's a two-edged sword. It actually can be useful in terms of getting some good messaging across. And there's a lot of great colleagues of mine internationally and nationally who are very effective and useful on social media. On the other hand, it is a very effective amplifier of the anti-science message, which includes things like anti-vaccine and anti-public health measures. And that part, unfortunately, has been the downside of social media. And regrettably, I can't say that one side is winning or the other. My perspective it depends on kind of what my mood is that day. But I sometimes feel that, the negative messaging from the anti-science folks is very prevalent. And one of the other things that we've run into is actually, instead of having, what I would call a good scientific discourse about something, some people who are otherwise, reputable scientists and reputable physicians and that have taken very extreme views on some things. And then that sort of generates rhetoric, which is not useful for the public to see. We should be having respectful dialogue amongst those of us who perhaps have different views on issues around COVID-19. And instead, social media has allowed the sort of idea that you can kind of bully somebody into your point of view. And that part I haven't been particularly happy with.
We have reached the end of our program today, and I certainly appreciate your time and all good information that you've passed along to us this morning. And all the best to you going forward.
Thank you very much, Dave, and thanks for having me on your podcast.
And once again, our thanks to Dr. Gerald Evans, a physician who has focused his research and practice studying infectious diseases. Hope some of his responses answered some of your questions. This episode was recorded on September 1st, 2021, using Zoom.
The theme music for the podcast is Stasis Oasis, written and performed by Kingston musician Tim Aylesworth. If you have any questions, comments, or suggestions about any of the episodes, please send a note to thekingstonianpodcast@gmail.com. For details on upcoming guests, follow us on Facebook. The Kingstonian Podcast is hosted by Dave Cunningham and produced in Kingston, Ontario, Canada.